Let's continue from question number 28, right? So we have a 71-year-old man comes to the emergency department due to sudden onset vision loss in his left eye for 1 hour. He has a history of coronary artery disease, hypertension, and type 2 diabetes mellitus. BP is 145 by 80 mm of mercury and pulse is 72 per minute. On examination, the patient can see only hand motions through the left eye. Fundoscopic evaluation of the eye shows a cherry red spot in the macula with surrounding retinal whitening. Cranial nerve examination is otherwise unremarkable. There is left-sided neck brute on cardiovascular examination. Which of the following is the most likely path of the embolus causing this patient symptoms? Option A, external carotid artery, facial artery, ophthalmic artery, retinal artery. Option B, external carotid artery, ophthalmic artery, retinal artery. Option C, external carotid artery, temporal artery, retinal artery. Option D, internal carotid artery, interior cerebral artery, retinal artery. Option E, internal carotid artery, ophthalmic artery, retinal artery. Pause it and give the answer. So the correct answer for this question is uh, option E, right? Okay, let us see to the explanation. Okay, you would think, why did I select this option? Because these are the branches which are supplying this retina, right? So first we have this internal carotid artery, right? And that would go and will branch to the ophthalmic artery, right? Let me, yeah, this one, ophthalmic artery, and that would give branch to the optic, the retinal artery that will enter into the optic nerve, right? And that would supply the retina. Okay, so retinal artery occlusion is an important cause of acute painless monocular lesion, uh, monocular vision loss, right? Thromboembolic complications of atherosclerosis in the internal carotid are the most common cause of retinal artery occlusion. This is important, right? The retinal artery is one of the first branches of the ophthalmic artery, as we talked about this. First, there will, okay, which receives its supply from the internal carotid artery. We recently talked about this. Like first, this is retinal artery. This would give branch to ophthalmic artery, right? And that would give branch to the retinal artery, and that would supply the retina of the eye, right? Okay. Why not option A and C? Because there are a number of anastomoses between branches of ophthalmic artery, which is the branch of what? Internal carotid artery. This is important. And branches of the external carotid artery, including facial artery and temporal artery, right? Although there are a lot of anastomosis between them, but neither branch anastomose with the retinal artery, right? Neither of this is anastomosing with retinal artery or supplying the which supplies the retina, right? So that is the reason. Okay, why not option D? This is important. The interior cerebral artery is the branch of circle of Willis, right, that supplies the blood to the midline portion of the frontal and superior medial parietal lobes. Okay, now this thing is important. Its occlusion can lead to loss of strength and sensation in contralateral lower extremity, with that incontinence and transcortical motor aphasia. These three things are important regarding this: loss of strength and sensation in contralateral lower extremity, with that incontinence, right? With that transcortical motor aphasia. Okay, the renal artery occlusion is a cause of acute painless monocular vision loss. It is usually caused by thromboembolic complications of atherosclerosis traveling from the internal carotid artery and through the ophthalmic artery. Okay, now in the next question, we have a 62-year-old man comes to the emergency department due to fever, productive cough, and dyspnea for the past several days. His symptoms are becoming progressively worse. The patient has underlying mild chronic obstructive pulmonary disease and has smoked a pack of cigarettes daily for the last 40 years. On examination, temperature is 38.3 degrees centigrade or 100.9 degree Fahrenheit. Pulse is 110 per minute and respirations are 24 per minute. Auscultation of the right lung reveals bronchial breath sounds and crackles. Lab evaluation shows leukocytosis. Chest X-ray is shown below, right? Like they have given this picture of X-ray. Okay, so they are asking the mediastinal contour obscured by the lung consolidation on this patient chest X-ray is primarily found by which of the following structures, right? So option A coronary sinus, option B inferior vena cava, option C pulmonary artery, option D right atrium, option E right ventricle, option F superior vena cava. So pause it and give the answer regarding this area. This is formed by which structure, right? So the correct answer for this question is right atria. Right for this question is right atria, right? Okay, because over here is the right area, right? Below that, um, below that it would form right ventricle, and if we move forward above, over here we have uh, superior vena cava and inferior vena cava right over there. Okay, so if we look at this, we have superior vena cava right over here, and then we have right atrium, and then when we go further down, then we have inferior vena cava, right? And this one is the right ventricle over here, right? And this one over here is left ventricle, right? Okay, and if we move in the backward direction, we have left atria over here, and this one is pulmonary artery, right? And when we go upward, we have aortic knob over here, right? And as we know that the pulmonary artery is on the right side, and that would cross over here to the left, and uh, the aorta is on the left side, it would move to the right side over here, just like that, right? So this patient has acute lobar pneumonia with consolidation involving the right middle lobe. The right middle lobe of the lung, it lies immediately adjacent to the right part of the heart, and any condition that increases radiographic density in the right middle lobe will obscure the adjacent cardiac fluid on posterior anterior chest X-ray (PA). Right projections. The right atrium composes most of the right side of the cardiac fluid. It is not the right ventricle, right? The right ventricle is forming the interior aspect, the most interior aspect of the heart, right? But the right atrium composes most of the right side of the cardiac fluid, right? Okay. So why not option E? The coronary sinus receives most of the venous drainage from the cardiac circulation. This is important point to be noted. It occurs it courses posteriorly around the heart in the coronary sulcus to empty directly into the right atrium, right? Directly into the right atrium. Okay. It is difficult to visualize on standard chest X-ray. Why not option B? Sorry. Why not option B? The inferior vena cava empties into the right atrium in the thorax, right? Okay, it composes only the most inferior edge of the right border of the cardiac fluid. Okay, it will form most inferior edge of the right border, right? Okay. Why not option C? Because the pulmonary artery can be seen on posterior anterior chest X-ray on the left side of the cardiomediastinal fluid, right? Just below the aortic arch. Why not option E? Because the right ventricle forms the interior wall of the heart, as I was saying about this thing. Best seen on the lateral chest X-ray, right? Okay. Then why not option F? Because the superior vena cava is found behind the first costal cartilage by the confluence, this is important, confluence of right and left brachiocephalic veins. Came they would come, right, and they will combine and they will form superior vena cava. Okay, on posterior anterior chest X-ray, it is flattened opacity parallel to the vertebral column, right? Okay, that terminates inferiorly at the right atrium. Okay, so on posterior anterior chest X-ray, the right middle lobe is seen adjacent to the right border of the heart. Okay, primarily found by the right atrium. Consolidation in the right middle lobe can obscure the X-ray silhouette of the right heart border. Okay, so in question number 30, we have a 33-year-old man comes to the emergency department due to fever, chills, cough, and shortness of breath over the last week. He smokes a pack of cigarettes a day, consumes 2 or 3 alcoholic beverages daily, and uses IV heroin. That means IV drug abusers, right? Point to be noted. Per week, he is febrile and tachycardic. Blood cultures grow staph areas. Important. It is related to IV drug abusers. Okay, chest X-ray shows bilateral nodular lesions with areas of cavitation. That means bilateral nodular lesions with areas of cavitation. They are showing septic emboli, pulmonary septic emboli, right? Okay. The valve most likely affected in this patient can be best evaluated by auscultation at which of the following sites? They're asking about auscultation points, right?